Hello everyone, my name is Magda Watabelo from Ethiopia. I am representing Group 01, the negative team, together with my teammate Ana Concepcion Polanco from El Salvador. Today we will debate with the affirmative team on the topic, should gene therapy be the first line treatment for childhood leukemia? To begin, we will briefly introduce childhood leukemia and the current standard treatment approaches. So, childhood leukemia is the most common childhood cancer and a major cause of cancer-related deaths in children. The main types are acute lymphoblastic leukemia. This is the most common by far, making up the majority of childhood leukemia cases. Acute myeloid leukemia, less common but still important type of leukemia in children, and chronic myeloid leukemia. This one is really rare in children. So the standard first-line treatments are multi-agent chemotherapy for acute lymphoblastic leukemia and acute myeloid leukemia with risk-adapted protocols, tyrosine kinase inhibitors plus chemotherapy for Philadelphia chromosome-positive acute lymphoblastic leukemia and for chronic myeloid leukemia. So with these treatment options, the 5-year survival rate in childhood acute lymphoblastic leukemia now exceeds 85 to 90% in many groups. Gene-based approaches, especially CD19 CAR T cells, shown impressive results in relapsed or refractory B-cell acute lymphoblastic leukemia, but not in newly diagnosed patients. So our key policy question here is that should gene therapy be the first-line treatment for childhood leukemia? And our position is no, gene therapy must remain reserved for relapsed or refractory cases due to effective current therapies, unresolved safety risks, extreme costs, and limited access, especially in low and middle-income country settings. Therefore, we advocate stewardship of proven accessible treatments first. As an opening statement, existing first-line therapies already cure most children with leukemia. Gene therapy, mainly CAR T, is transformative for relapsed or refractory B-cell acute lymphoblastic leukemia, but it is still associated with serious toxicities and high treatment-related costs. So, making gene therapy first line would expose millions of curable children to unnecessary risks, and it may deepen global inequities because gene therapy is largely unavailable in low resource settings. Therefore, gene therapy should not be first line treatment for childhood leukemia. So, as a constructive argument one, current first-line treatments are highly effective, and the core claim is simple that we do not replace what is already working. In B-cell acute lymphoblastic leukemia, which is the most common type, moderate risk adapted chemotherapy achieves more than 90% 5-year survival rate. For T-cell acute lymphoblastic leukemia, using current protocols delivers 80 up to 85% survival rate, and in Philadelphia chromosome positive acute lymphoblastic leukemia, adding tyrosine kinase inhibitors like imatinib or dasatinib to chemotherapy has dramatically improved outcomes, which is far better than historical rates. For the rare chronic myeloid leukemia in children, tyrosine kinase inhibitors are now the effective first-line therapy and have largely replaced the need for transplant in most cases. Importantly, guidelines worldwide do not recommend CAR T or gene therapy as routine first-line treatment. So, in conclusion, with survival rate of 80 to 90%, replacing first-line chemotherapy or tyrosine kinase inhibitors with gene therapy is not simply evidence-based. Overall, risk-adapted multi-agent chemotherapy achieves above 90% survival in standard risk childhood acute lymphoblastic leukemia, and approximately 85% in many high-risk groups. And it is also proven across decades of large international trials, and it is effective beyond high-income countries when proper supportive care is available. As a result, most newly diagnosed children can be cured with chemotherapy and thyroid kinase inhibitors without experimental gene therapy. Our next argument is gene therapy's proven role nowadays is limited. As a claim statement, CAR-T and TCR engineered T-cell therapies are mainly effective in relapsed or refractory leukemia, and evidence suggested that CAR-T and TCR therapies benefit patients after transplant or failure of chemotherapy. Relapsed or refractory B-cell acute lymphoblastic leukemia patients' 1 year overall survival after gene therapy is approximately 60 to 80%, and their 2-year remission is 40 to 50%. In acute myeloid leukemia cases, post-transplant WTI-specific TCR therapy showed no clear improvement despite acceptable safety. As a conclusion, gene therapy is not yet a reliable first-line treatment, even in a very high-risk leukemia cases. Our third argument is safety concern and limitations. And the claim statement here is gene therapy carries significant safety risks and it remains experimental, making it unsuitable as first-line treatment for children. Some of the toxicities or safety concerns associated with gene therapies are the first one is cytokine release syndrome, which is in which the immune system overreacts in 70 to 80% of patients, and even in 10 up to 20%, it becomes severe and cause dangerously low blood pressure, breathing difficulty, and organ problems that often require an intensive care visit. And secondly, it might cause neurotoxicity or ICANS because it affects or it occurs in a substantial proportion of patients, and 20 up to 40% get symptoms like confusion, speech problems, or seizures. And in severe cases, around 10 up to 50% might need strong treatment or constant monitoring. And the third one is viral vector risks. These delivery methods can sometimes cause insertional mutagenesis, or genes might be inserted incorrectly, and it may raise the possibility of secondary cancers like leukemia. Therefore, in conclusion, given these serious risks, gene therapy is justified only after standard treatments fail, or when the benefits outweigh the dangers, and children already have fewer safe options, not as first-line therapy for children. Our constructive argument for is cost and access barriers make first-line gene therapy impractical, and the claim statement here is the extreme cost and infrastructure requirements of gene therapy make it unsuitable as a global first-line therapy, and evidences worldwide suggested that CAR-T therapies, like that of Kymriah, are very expensive since they cost approximately 475,000 United States dollar per infusion, plus to that of high hospitalization and ICU expenses. In this scenario, even high-income countries struggle with affordability issues, and low and middle-income country access is described as all but impossible because most low and middle-income countries lack apheresis, cell processing, and critical care infrastructure to deliver CAR-T safely. So as a rebuttal, the first claim of the affirmative group is gene therapy is more precise and less harmful. And as a oppositional counter-argument, evidence suggests that chemotherapy cures 85 to 92% of cases with toxicities we know how to manage, but CAR-T adds severe CRS, neurotoxicity, and lifelong B-cell aplasia, which often requires an ongoing intravenous immunoglobulin therapy. And their second argument is gene therapy has a higher remission and prevents relapse. Of course, CAR-T achieves over 80% remission rate, but only in relapsed or refractory patients. But when we come to the frontline chemotherapy, it achieves above 98% complete remission and low relapse in standard risk acute lymphoblastic leukemia cases. And their third argument is it reduces long-term complications. As an oppositional counter argument, we said that chemotherapy late effects increasingly mitigated through risk-adapted protocols, but CAR-T therapy introduces persistent B-cell aplasia and infection risks with long-term data still limited. And therefore, the argument claim is ethical responsibility to offer most advanced. So as an oppositional counter-argument, we said that ethics requires proven, safe, and equitable therapy, but CAR-T remains unaffordable and inaccessible in low and middle-income countries. And their final claim is cost will drop and access will expand soon. So as an oppositional counter-argument, gene therapy, like that of CAR-T therapy, still costs 475 to 700,000 United States dollar per course, but chemotherapy is way better than this gene therapy, since it costs less than 500 to 20,000 United States dollar. And additionally, there is no credible forecast for near-term price parity. As a closing statement, gene therapy is a promising life-saving option for some children with leukemia, especially those who relapse and who are in refractory stages of childhood leukemia. But as a first-line treatment for all childhood leukemia cases, it currently lacks long-term safety data. It has serious unique side effects. It is extremely expensive and difficult to access, and it raises complex ethical and practical challenges. Therefore, we concluded that gene therapy should not be the first-line treatment for childhood leukemia. Instead, it should be used after standard therapies or within carefully controlled clinical trials. These are our sample references that we use to develop our debate sessions. Finally, we want to say thank you for coming this far with us, and if you have any questions, we are happy to provide answers.